Hello everyone, how are you all? So today our topic of discussion is fetal surveillance and antenatal care both. Okay, so from these both topics, one or two questions come in every exam. Okay, mostly in the previous years, question were coming from antenatal care. Okay, but in the last May 22 INICT exam, there were two questions from fetal surveillance. So, as you all know, that INICT sets the trends for every exam. So, in this NEET PG and FMG, it's quite expected that we are going to get one or two question from fetal surveillance. Okay, so this time you are going to study the fetal surveillance sincerely, not superficially. Okay, so let's start this topic, fetal surveillance. Okay, so first of all, what does the word surveillance means? Surveillance means to monitor, and fetal surveillance means to monitor the fetus while the fetus is in utero. So there are two types of fetal surveillance: antenatal fetal surveillance and intranatal fetal surveillance. Antenatal means that while the female is pregnant, to take care of the fetus, to monitor the fetus, whether the fetus is safe or whether the fetus is in danger. And intranatal means when the woman is having contractions or when the woman is in the labor, then how we have to care the fetus, where the fetus is able to take that contraction, to bear that contractions, or the contractions have are creating any hypoxia to the fetus, all those things. Okay, so that is what is two type of surveillance: antepartum surveillance and intrapartum surveillance. Okay, in antepartum surveillance we have these 6 tests. Okay, first of all is DFMC, which is also known as Cardiff count 10, Cardiff count of 10. Okay, then is non-stress test, then is vibroacoustic stimulation test, then is biophysical profile, modified biophysical profile. On these two topics question came on INICT. Okay, we will also be having the questions in between, so that we should know which topics are more important and which are not. And in the last is Doppler velocimetry or Doppler. Okay, so now let's study what's the fetal kick count. And from ancient days, we are monitoring the fetus by clinical assessment, by seeing whether there is weight gain or not, or whether the fundal height is increasing with the increase in the period of gestation, and whether the abdominal girth is increasing or not. So these were the parameters. Traditionally, these were the only parameters by which we were assessing the fetal growth, fetal well-being. Nowadays there are a lot of parameters. Now first of all, it is the fetal kick count. Okay, now you all know that when fetus is in the when the lady is in the 6th month of the period of gestation, the female feels the kicks of the fetus, right? So that female has to assure that the fetal is active or not, and the fetal is okay or not, or so the female has to count that kicks. Okay, so in 12 hours, Cardiff told that in 12 hours, Cardiff told that in 12 hours the count should be at least 10. Okay, the kick count should be at least 10, then it means it is okay. Now that 12 hours will be the 12 hours and that 12 hours will be those 12 hours in which the patient is awake, not sleeping, right? So 9 a.m. to 9 p.m. They calculated that this is the average time. This is the time when almost every female is awake. So they said that from 9 a.m. to 9 p.m. there should be 10 kicks should be there. So that is known as the Cardiff count of 10. Now for some females it was quite hectic for the 12 hours they have to pay attention whether the kick is whether the fetus is kicking or not. So for them a modified version was tell that after every meal you should be cautious for 1 hour. Okay, and so we take 3 meals in a day, so they have to be cautious only for 3 hours, and then they have to add all those kicks. Take it for example, in the breakfast it was, if it is was 4, and in the lunch, after lunch, post lunch hour it was 2, and in the dinner it was 6. So 4 plus 2 is 6, plus 1 is 7, and then in those cakes we have to add 4, and that count we have to add 4, and that count should be more than 10. So adding in the post meals 1 hour cakes, adding the 4 to that, we should be more than 10, and or one has to be cautious for the 12 hours, and the count should be more than 10. Okay, so this was about the fetal kick count or Cardiff count of 10. Now there is non-stress test. Second test is non-stress test. Okay, what is non-stress test? We don't give any stress to the patient. Okay, still again I would like to tell you that we are studying here antepartum fetal surveillance. Okay, it's not that the fetus is in contractions, or it's not intrapartum fetal surveillance. Okay, one point I forgot to tell you about the fetal kick count is that the fetal kick count is started after 28 weeks. Okay, so non-stress test is based on the principle that the autonomic nervous system, it develops at 28 weeks, and it is fully active at 32 weeks. Okay, so after 32 weeks we have to perform this NST, right? And it is on based on the principle that if fetus autonomic nervous system is working fine, then with every kick the fetal heart rate should raise. Okay, so if the fetal heart rate is raising, it means the fetal is active, and fetus is normal. Okay, so it is based on this principle. And if the fetus is suffering hypoxia, or fetus is having acidemia, then it means that there will be no increase in the heart rate with the fetus movement. Okay, so there will be no increase in the fetal heart rate with the fetal movement. And if there is increase in the fetal heart rate, it means the NST is okay, and the autonomic nervous system, sympathetic and parasympathetic nervous system, they are functioning very well. Okay, and this test is done after 32 weeks, because at that time the autonomic nervous system is being fully functional. Okay, so let's study the next slide. So this machine can come, this is a NST machine. Okay, so you can see here that here the paper is coming out, and the graph which is on the paper is also here on the monitor. Okay, and if you are able to see, I think you are not able to see. Yeah, now you're able to see. This is 147 is the fetal heart rate. Okay, this 147 is the fetal heart rate. Okay, so it's quite obvious that one can get a false report of negative or non-reactive NST. One can get, and the most common physiological reason is that the fetus is sleeping. Okay, because when the fetus is sleeping, the fetus will not move, and when it will not move, there will be no rise in the fetal heart rate. So we might think that this NST is negative or non-reactive, but the reason is, physiological reason is behind here, that the fetus is sleeping. Okay, and the most common pathological reason which is there behind the NST, behind the non-reactive NST, is that fetal hypoxia is there. Okay, negative NST or non-reactive NST is that fetal hypoxia. Most common pathological reason is fetal hypoxia, and most common physiological reason is fetus is sleeping. Okay, so now we will learn how we have to arouse the fetus and how we have to awake that sleeping fetus. That all we are going to learn. First, let's study when it is done. Okay, when this NST is done. So NST is done in every female after 32 weeks weekly. Okay, we were doing the Cardiff count also weekly. Okay, and NST is also done weekly in every female after 32 weeks. Okay, and if that patient is a high risk pregnancy, if that female is a high risk pregnancy, then we are going to do NST twice weekly. Okay, we are going to do it NST twice weekly. Okay, and if that patient high risk is diabetes mellitus, as you all know that diabetes mellitus can cause death of the fetus, right? So that is why we increase our fetal monitoring frequency, right? If it is controlled, then we do it in once in every 48 hours in both diabetes mellitus, controlled diabetes mellitus and hypertension. And if it is an uncontrolled diabetes mellitus, and it's high chances are there that this fetus is going to have IUD, so we do the NST daily. Okay, so these are some of the important points about NST frequency, when to do. In a normal patient after 32 weeks we are going to do the NST weekly, and in a high risk patient we are going to do every 72 hours or twice a week. And if there is a diabetes mellitus, we will increase our frequency, and rather than doing every 72 hours we will do once in 42 hours. And if it is uncontrolled diabetes mellitus, then we are going to do it daily. Okay, because high chances of IUD are there, and the NST can change quickly. Okay, next is, let's see how we have to read the NST. Okay, so when we are doing antepartum surveillance, right? And in it we are doing NST. In that NST, in that NST we have to see only two things. The first is, yes, the first is we have to see that accelerations are there or not. While describing the NST, I told you that with fetus movement there is a rise in the fetal heart rate, right? I told you with the fetus movement there is a rise in the fetal heart rate if autonomic nervous system is functioning, right? I told you. Now if now that rise in the fetal heart rate we have to see. So in 20 minutes there should be 2 rise in the fetal heart rate, and for that there should be 2 fetal movements at least. Okay, so in a 20-minute testing period, that's a minimum testing period, at least 2 acceleration in the fetal heart rate should be there. And what is, to which rise we say that this is the acceleration? So you are saying that here also the fetal heart rate is raising, but we are counting the rise only this. Why is it so? Because as per the definition, only that rise which is 15 beats above, so that only that rise we are going to consider it. Okay, for example, this is it, here the baseline was 130 and this has touched 170. So to say it a rise, or to say it a acceleration, that should be 15 beats above the baseline, So this is the baseline. So this rise should be 15 beats above. Okay, and here on this axis there is the fetal heart rate. There is already on the paper also there is written, and on the monitor also it is written fetal heart rate on the y-axis, and x-axis is the time. Okay, so as that acceleration is a true acceleration in which the rise is 15 beats above the baseline, and that rise duration should be 15 seconds. Okay, and that rise duration should be 15 seconds. Okay. Okay, so that is one acceleration. The rise 15 beats above rise, and for 15 seconds. So that is one. So those at least two accelerations should be there in 20 minutes, and that is only possible if that fetus is having two movements. Okay, so if that fetus is having it, if that two rise are not present, then we say that it is in the 20 minutes, then we say it is a non-reactive NST. And if these two accelerations are present, then we say that it is a two acceleration or two rise of fetal heart rate are present, then we say that it is a reactive NST. Okay, reactive, non-reactive. The second thing which we have to understand about the NST is the beat to beat variability. Now you have seen that here when I have drawn the line, exactly this line was not a straight line. I have to draw that baseline, right? Now let me draw this line. This line is changing. See, the beats, they are changing, and this is a good sign. This variation in the beats should be there. Okay, this is acceleration, this is acceleration, this is acceleration, rise in the fetal heart rate, and this baseline variability, beat to beat variability should be present. This is good, and if this is absent, then also we say that this NST is non-reactive. Okay, so let's have a look at abnormal NST. So here both acceleration is also absent and beat to beat variability is also absent. So if we get such a type of NST, we have to label it as non-reactive, right? And if we get the NST like the before I saw you, we have to label it as reactive NST, and we have to mark there one acceleration, two acceleration, right? Okay, and then this is the you can see that this is more so over a straight line, no acceleration and no beat to beat variability. If we get such type of NST, one option is that the fetus is sleeping. Okay, so we are going to repeat that NST for 20 minutes to rule out whether the fetus was sleeping or not. Okay, so it's quite high chances that in the next 20 minutes the fetus will be awake, and we will get a reactive NST if the reason was sleeping. If there was a pathological reason of fetal hypoxia, then it is then the NST will be the same. Okay, I hope you understand. Let's go to the next slide. So this is vibroacoustic stimulation test. Okay, we all have seen the Three Idiots movie. Okay, you all know that in Three Idiots, okay, that fetus with whose delivery Karina did was sensitive to the sound. All is well, right? Yeah, it was a dramatic, but that is the same thing. So the fetuses, they are sensitive to sounds which have lot of vibrations. So I don't know all is well is having or not. So if a sound with a lot of vibrations come, then if the fetus is sleeping, it awakes and moves, and there is increase in the fetal heart rate. Okay, so that is what is vibroacoustic. It is an artificial larynx we have made. Okay, where while I was doing PG, we were not having this device, so we used to clap. Okay, so clap also creates a sound and also creates vibration. So we used to clap when we find that the fetus is sleeping. We have a doubt that fetus is sleeping while doing NST. We used to clap. Okay, so nowadays I think you all must be having this in your colleges while you were doing your internship you will be having this device. So it is known as vibroacoustic stimulation test, is also known as VAS. So we got a device, we on the device, so from the device sound comes and high vibration come, and the startle reflex of the fetus is active, and then the fetus moves, and there is if there is increase in the fetal heart rate with the movement of the fetus, then the fetus is fully okay or well-being. This fetus is well, and if it's not there with the, if there is no rise in the fetal heart rate with the movement of the fetus, it means the fetus is in the problem. Okay. Okay, so now let's see the next question. This is a question from INICT May 22, and this is going to change the trend. As I already told you, what is incorrect regarding the BPP? BPP is biophysical profile, which is our next surveillance test, biophysical profile. Okay, so let's see. Biophysical profile, it consists of first option was we have to tell with what is incorrect. Okay, so first option is biophysical profile consists of AFI, fetal gross body movement, fetal tone, fetal breathing movement, and fetal heart rate reactivity. Next is biophysical profile correlates with the fetal pH and fetal outcome. Next is biophysical profile less than 4 indicates pH less than 7.2, and biophysical profile less than 2 has 100% sensitivity for acidemia. Score is inconsistent with the fetal pH at different gestational ages. So here the D point is incorrect, rest all the 3 points are correct, and score is same with fetal pH at all the ages. Okay, so let's study this biophysical profile in detail. One more question from CT May 22. It was on the modified biophysical profile. Okay, what is modified biophysical profile? It is option A is correct. It is AFI plus NST. I know you, all of you know this, as you all know that this is very important. So let's study biophysical profile in detail as required by the examiners. Okay, so first of all, here we are going to do a NST, and we are here and we are going to do the ultrasound of the fetus, and by these two sources we are going to make this biophysical profile, or we are going to make that score. So this is also known as Manning score. First thing, in all the pregnant patients we are going to do, no, we are not going to do in all the patients. We are going to do only in the patients which have loss of fetal movements and those which are high risk pregnancies. Okay, so we are not going to do in all the patients. We are going to do in the patients which are high risk pregnancy and in which there is loss of fetal movements. In only these two conditions we are going to do. And last two tests, NST and kick count, that we were doing in all the patients. Okay, so let's see what are the 5 components. Of course, first component is NST and the second component is AFI that we get on ultrasound. From the ultrasound we get 4 parameters. Okay, some students complain me that ma'am, it's very difficult to learn all these 5, make a mnemonic. So mnemonic is ban motto. Okay, either you can do it from mnemonic or you can do it with like this also. How I remember, I'm going to tell you. First of all, as we're going to study a few minutes later, that modified biophysical profile is NST and AFI. Okay, so these two you have to remember, because we in our clinical practice we are only doing modified biophysical profile, because biophysical the most important thing in the biophysical profile are these two, AFI and NST. Okay, so we only do this two, because the rest of all these things they cost 30 minutes. Okay, assessing all those parameters, they cost 30 minutes. So in clinical practice in India we have a lot of patients and we can't wait for 30 minutes to get this score done. So these two things we all remember. Okay, and in examination you have seen that we have also got a question on modified biophysical profile. What is biome? So we know that age is AFI and NST, and these are the 2 most important parameters out of the 5. So now we left with 3 which we have to remember. The 3 are, what are the 3? Number 1 is fetal movement, another is fetal breathing movement. Easy to learn. Two parameters are associated with the movement. One is fetal movement and the another is the fetal breathing movement, and the third and the last parameter which is left is fetal tone. Easy. So what is fetal breathing movement? Fetal doesn't breathe, we know, while in utero fetus doesn't breathe. So what is breathing movement? Breathing movement is the fetus swallowing movement. You all know that fetus drinks its own amniotic fluid, right? Fetus drinks its own amniotic fluid. That swallowing movement is taken as its breathing movement. Okay, so the 5 components of the Manning score or biophysical profile is, first of all, 2 components of the modified biophysical profile, NST and AFI, and next number 3 is the fetal movement and fetal breathing movement, and in the 5 the last one is the fetal tone. Okay, so the each component we are giving 2 marks. If the NST is reactive, 2 marks. If AFI is normal, 2 marks. If fetal movement is normal, it is 2 marks. It's the movement of the limbs, right? And if fetal breathing movement actively, if it is swallowing, it's 2 marks. And if fetal tone, last is fetal tone. If fetal tone is okay, then it is 2 marks. In total, maximum score is 10. Okay, and in modified biophysical profile already discussed, it is NST and AFI only. So to get all these 4 parameters of ultrasound, we have to it takes 30 minutes. Okay, so rather than devoting time to those parameters, we just focus on 2 parameters, AFI and NST. Okay, now the last test, as we have done all the tests, as I showed you in the first slide, we have done the daily fetal movement count, DFMC, and we have done the non-stress test, we have done the vibroacoustic stimulation test, biophysical profile and modified biophysical profile, and these are done if there is loss of the fetal movement and if there is it's a high risk pregnancy. And in the last we have last test of antepartum fetal surveillance is the Doppler velocimetry. So let's go to that Doppler velocimetry. So what is Doppler velocimetry? Fetal Doppler means knowing about the blood flow. So fetal Doppler means to know about the fetus blood flow, how the blood is flowing in the fetus. Okay, so you know that if the fetus is suffering hypoxia, the blood flow will be also altered, right? So in which arteries it alters, we are not going to see each and every artery of the fetus and assess it. We have to see the important arteries. Okay, so first of all we can see it in these 3 arteries: uterine artery, umbilical artery and ductus venosus. Okay, so these are the 3 important arteries which will tell us about the fetal well-being. Okay, so these are in the ascending or increasing order of their importance. So less important is uterine artery. Of course, this all 3 are important. Less important is uterine artery. Okay, so uterine artery is the artery which is supplying the fetus. So if there is any problem in the uterine artery, so there are high chances that the fetus is going to suffer. Okay, so uterine artery. Now uterine artery, then there is umbilical artery. Okay, so umbilical artery is the artery which carries the deoxygenated blood from the fetus. So now it is more near to the fetus, so its chances is to get affect, its blood flow to get altered is more than the uterine artery. And now is the ductus venosus. It's the most susceptible artery. Okay, so in the previous year questions, they have asked about which is best among the uterine and umbilical. Okay, so we have marked the umbilical, but they have not put the ductus venosus in the option. But these days they can put, as you know that this topic is getting important. right? So the best is ductus venosus, and on the second number is umbilical artery, and on the last number is the uterine artery. And of course all these three are important. It's better to know about all this flow. So let's study first of all what is the normal blood flow in these arteries. Okay, you know that every human heart has high blood flow in the systole, and it has a less blood flow in the diastole. That is when heart is not contracting, but there is a flow. It's not that we have a normal blood pressure of 120/80. So when we get a blood pressure of 120, it means that our heart is pumping, so the pressure raised. And when it is 80, our heart is not pumping, but still there is some pressure maintained by our body, and that is 80, right? So in a similar way, this is the normal blood flow. So this is the blood flow in the systole. So this is the blood flow in the systole. These peaks are in the systole. The blood flow has increased, right? And these down peaks, these are diastole. Okay, and these down peaks are diastole, right? Okay, got it. And this high peaks are systoles. Okay, so first the blood pressure raises, then the blood pressure comes down, flow comes down, then flow is stationary in diastole, then it again raises in systole, then again comes down, then it's stationary. This is the normal graph which is found in the arteries of the fetus. Okay, this is a normal graph. Now let's see what happens when it is compromised. Fetus gets compromised or suffers hypoxia. In the initial stages, what happens is that the diastolic notching is there. Okay, now this is the diastole falling. Here there is a notching. Some abnormality is there. Okay, let me change the pen. Yeah, here is notching, this notching, this notching, this notching. These all are the diastolic notching, and they are found in the initial stages of the fetal compromise. Now let's go one stage ahead. One stage ahead. Okay, so let's see here. This is the second stage. Here we are seeing the blood flow has fallen. Okay, initially they were up till this, the flow was up till this level in the diastole, but now it is initially the flow was up till this level, and now this peak is not here, it has gone down. It has gone down. You can see that the peak is not up till here, it has gone down. So there is no flow in the diastole, and this is somewhat abnormal. If our BP is 120/0, it is abnormal. In the same way, this absent diastolic flow is very abnormal. Okay, here we have got the time of only 2 to 3 days. It is much likely that the fetus will survive for 2 to 3 days. Okay, the high suspicion is there that this fetus will die in 2 to 3 days if we get the absent diastolic flow. This is known as absent because here in the diastole no blood flow is there, right? So now third stage is this, and the last. What is happening here is that rather it's absent, it has reversed. Now the blood flow from the blood flow is going to mother. Initially what was happening, from the blood was coming from mother to fetus, and now from the fetus the blood is going to mother. Okay, so now this is the last stage. You can see that the blood is going in the negative direction. It means it is going to the mother. It is a reversal of the diastolic flow, and this is a this is a emergency. This is a emergency. Cesarean has to be done now. Okay, cesarean has to be done now. So that was all about the antepartum fetal monitoring. So let's revise it once again, slide by slide. First of all, there are six tests in total of there are 6 tests in total of antenatal surveillance. 2 are biophysical profile and modified biophysical profile. One is kick count, another is NST, and one is vibroacoustic stimulation test, which is also known as VAS, and in the last is the Doppler test. Okay, the last 3 biophysical profile, modified biophysical profile, and the Doppler is done in the high risk or on any indication. The above 3 are done in all the patients. Okay, and this is the NST machine. Okay, and this is the reactive NST. 2 acceleration should be there in the 20 minutes, and what is 1 acceleration is 15 beats more than the baseline, and that beat increase should last at least for 15 seconds, and there should be beat to beat variability. And what is non-reactive NST? Non-reactive NST is the beat to beat variability has gone and there is no acceleration. So most common physiological reason for that is that the fetus is sleeping, and most common pathological reason is that the fetus is having hypoxia. So we need to do the NST again for 20 minutes to rule out the cause of fetus sleep. Okay. VAST is an artificial larynx which has a sound and vibrations. This arouse the fetus and fetus moves, and if there is increase in the fetal heart rate, it means that the fetus is active, and if there is no increase is with the fetal movement, it means the fetus is non-active. Okay. So this was about the biophysical profile. In the first option, they have given all the 5 components. Yeah, it's true. Next is the fetal pH. Yes, fetal hypoxia and fetal outcome biophysical profile correlates. And the third point is also right, that if the biophysical profile is less than 4, it means the fetus is having hypoxia, or acidosis is one and same thing, less than 7.2. And if it is less than 2, lowest score is less than 2, it is 100% sensitivity for fetal acidemia. Okay, so score is inconsistent with fetal pH. No, it is consistent with fetal pH at all the gestational ages. Okay, modified biophysical profile. This was an easy question. Then what is biophysical profile we have discussed. Now let's see, we have seen Doppler. In the Doppler we mainly assess 3 arteries, uterine umbilical artery and ductus venosus ductus venosus is the best artery to do. Number 2 is the umbilical artery, and number 3 is the uterine artery. Okay, next is so these are the 3 stages. This one is normal, don't get confused. This one is normal, and this is the first stage of diastolic notching, and this is the second stage of absent diastolic flow. Here there is absent diastolic flow, and in the last stage there is reversal in the flow in the diastole, and that is emergency. Okay, so that's all about the antepartum fetal monitoring. Let's study about the intrapartum fetal monitoring. So intrapartum fetal monitoring, we basically have 2 things, not 6 tests. It's very easy. Okay, let's focus. First is the auscultation or intermittent auscultation to see the fetal, to listen to the fetal heart rate. Okay, we can listen it, either we can listen it by this fetal Doppler. This is the image of the fetal Doppler. Okay, so this is the probe. Okay, this rest of this instrument we put in our hand, we take out this probe. Okay, and we put this probe on the fetal abdomen here. Okay, and this is a speaker, and from here the sound of tuck 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 come, and this is the number. What is the fetal heart rate? Here is a number. So we don't have to count. It's very easy. Almost all of the gynae residents, they have this in their pockets. So this is it. So let's see how to use this, and this is known as fetal Doppler. And another thing is a fetal scope, the traditional one, and third thing by which we can listen to the fetal heart rate is stethoscope. Okay, so whatever we are using, it hardly matters, but you should know that we have to auscultate it for 60 seconds. It's not that you have to just place the fetal stethoscope and we have to say that yeah, in the fetus is okay. No, when the mother is having contractions, the mother is in the pain, then we have to auscultate it for 60 seconds. We have to count it. Okay, and if the patient is in the first stage of the labor and patient is low risk or normal patient, then we have to auscultate every 30 minutes. And if the patient is high risk pregnancy, then we have to auscultate it every 15 minutes. And as the patient goes into the second stage, we have to auscultate the fetal heart rate every 5 minutes. Okay, so seeing all this scenario, it is much likely that only one staff can take care of the laboring patient at the one time. Okay, so it's true that only one staff can take care of her, because we have one or the other patient is high risk. So every 15 minutes we have to take. So we can't take care of the other patient. Okay, so and for the full 1 minute we have to listen the heart rate. So for 60 seconds after every 30 minutes or 15 minutes in the first stage of the labor, depending whether it's a low risk pregnancy or a high risk pregnancy, and in the second stage every 5 minutes. Okay, now let's see, this is a question from INS May 2017. They are asking that deceleration type. It's a deceleration are of 3 types: early, late, and variable. So one type is variable, and which variable deceleration is significant. Okay, so this we are going to discuss, and again we will come to this question. Okay, now let's see. Another test, one test which we are going to do for the intrapartum fetal monitoring is auscultating the fetal heart rate. Okay, that I told you, we have to auscultate for 60 seconds every 30 or 15 minutes in the first stage, and every 5 minutes for the second stage of the labor. Okay, now let's see components that need to be checked. Okay, so what all factors we have to see in the cardiotocograph. Here we have to see the fetal heart rate. So it is totally different from the NST. Okay, in the NST the fetus was having no stress. That is why it was named non-stress test. We were seeing 2 parameters. What were those parameters? Beat-to-beat variability and acceleration. Here we have to see 4 parameters. Now the fetus is in stress of contractions. Now we have to see 4 parameters. What are those 4 parameters? Number 1 is fetal heart rate. Okay, so normal fetal heart rate is 120 to 160. Okay, 120 to 160. So now we have to see fetal heart rate. What's the baseline fetal heart rate? That baseline. Okay, whether beat to beat variability of 5 to 15 beats is present or not. Same that thing. Third is accelerations are present or not. And number 4 is, now as 4 is the most important thing, deceleration. Acceleration was rise in the fetal heart rate, 15 beats rise for 15 seconds. And now deceleration is fall in the fetal heart rate more than 15 beats for more than 15 seconds is known as deceleration. So if any deceleration is present, then we have to note it. And the reason for that is fetal hypoxia. Fetus is getting affected. Let's see which deceleration is important. As I already told you, there are 3 types of fetal deceleration. What are those 3 types? early, late, and variable. So what is early? Let me tell you. See here. Early means that the it is coming with the contraction. Okay, here what is the factor which is deciding early or late? If it is coming with the contraction, coinciding with the contraction, it is early. I am not telling it before the contraction. Okay, I am telling it is coinciding with the contraction. Okay, so in the cardiotocograph we have two graphs. First, the above graph is of the fetal heart rate and the lower graph is of the contractions. So we have to see what is the relation of the deceleration and the contraction. If both are coinciding, contraction peak and the deceleration peak is coinciding, it means it is a early deceleration. Okay, and when it is there, see, it is during the head compression. When the head gets compressed, head has to pass through a narrow pelvis, and then vagina is much more narrow than the pelvis, right? So when the head is getting compressed, we get early deceleration or fall in the fetal heart rate with the contraction. What does early deceleration mean? Early deceleration means fall in the fetal heart rate with the contraction. Okay, so what does it indicates? It indicates that fetus head is getting compressing and that the fetus head is in the vagina and it is getting compressed, and it is a very normal thing. It does not affect the fetal outcome, and it is a very, very normal thing. It does not affect the fetal outcome. Let's see a graph of the early deceleration. Okay, see, this is the deceleration. Now it is fall is more than 15 seconds and more than 15 beats, and this is a contraction graph. I told you two graphs are there. One graph will be of the deceleration of fetal heart rate and another graph will be of the contraction, and we have to see. Now you can see that both of their peaks are coinciding. Once again, here is another deceleration and here is another contraction. Their both peaks are coinciding. It means that this is a early deceleration. Okay, any doubts? And why it is there? It is due to the head compression. So if question asks what is the deceleration we mostly get while in the second stage, what you will say? What you will say that it is a early deceleration. Most common deceleration in the second stage is early deceleration. Okay. Next is late deceleration. What is late deceleration? Late deceleration means that it starts after contraction and it is seen in the uterine insufficiency. It starts after contraction. That is why early was known as early, because this is after contraction. Okay, late deceleration means the deceleration which is coming after contraction. Okay, and it is the most khatarnak, dangerous deceleration. Okay, and it is seen in the uterine insufficiency. Okay, the last deceleration is the variable deceleration. Okay, and this deceleration has no relation with the contraction. It does not come with the contraction and it does not come after the contraction. It has no relation with the contraction. Okay, it is a variable deceleration. That is why that is how its name is. It has no relation with the contraction and it is seen in the cord compression. Okay, these three words you have to remember. Early contraction coincides with contraction and seen in head compression, no effect on the fetal outcome. Late deceleration starts after the contraction, affects the fetal outcome, and it is seen in the fetal insufficiency. Variable deceleration, no relation with the contraction, and it is due to the cord compression. Okay, and usually it doesn't affect, but there is a case when it affects, when it is severe. So well, let's see what is severe. Okay, this first A option is mild variable deceleration. This second option is moderate. These both, if they are present, then they don't affect the fetal outcome. But when this third is present, then it is known as severe variable deceleration, and then it gets significant also. That was what it was asked in AIMS May 2017. Okay, what is mild variable deceleration? That the fetal heart rate is falling less than 90 for 60 seconds. Fetal heart rate is going less than 90 for 60 seconds. Okay, and what is moderate? Moderate is fetal heart rate is going below going below 80 beats per minute for 60 seconds. It is moderate. And if the fetal heart rate is going below 70 beats, then it is a severe and significant variable deceleration. This variable deceleration is going to affect the fetal outcome. Okay, so that is why it was asked in AIMS May 2017. Okay. Now let us see how we will, this is a graph of the late, so you can late deceleration. This is the peak and this is the contraction peak. You can see that it started just after the contraction. Here again is this peak, and here again it started just after the contraction peak. So this is the example of late. Okay, the one which was called coinciding peaks, that was the early deceleration. The one which has no relation, this is the variable deceleration. See, it is coming when there is no contraction. So this is a case of, nonetheless, this is a case of cord compression. So you can write on the NSTs if you know. Last but not the least is the sinusoidal pattern. It is seen in the fetal anemia, and this pattern sinusoidal. Okay, so you all know that this sinusoidal pattern. What is sinusoidal pattern? Sinusoidal pattern is peak, up peak and a down peak, and it is seen in the fetal anemia. Okay, it is seen in the fetal anemia. Okay, and below graph is of the contractions. You can see that it is seen in the fetal anemia. What are the conditions where we get fetal anemia? Was a previa, Rh negative incompatibility. There we get this type of the fetal graphs. Okay, last but not the least, third type is the fetal blood sampling. This we rarely practice in clinically. So you can say that we have to sample the blood of the fetus while the fetus is in the utero. It's very difficult. Okay, and the normal pHs, you just need to remember that normal pH is 7.3. This is normal, and less than 7.2 is acidic. It means this is the indication of emergency cesarean. Okay, so you just need, because it's not followed practically, lessons are there, they will ask you. You just need to remember this value, that normal fetal pH is 7.3, and if it is less than 7.2, it means that the fetus is acidic. Okay. Next question is from the NEET PG 22. This was now our topic, antenatal care has started. So let me revise the intrapartum surveillance first. First step in the intrapartum surveillance is auscultation of the fetal heart rate, that we discussed nicely. Then next is the CTG. In the CTG, we have to, beside noting the beat to beat variability and acceleration presence, we have also to note the deceleration, which type of deceleration, and fetal heart rate value. Okay, So there are three type of deceleration: early, which is early deceleration, which is coincides with the contractions, and they are found in the head compression. The late decelerations are the decelerations which comes after the contraction, and they are very dangerous. They are found in fetal hypoxia. And variable deceleration rarely affects the fetal outcome. Only the severe type they affect the fetal outcome, and they are seen in the cord compression. Okay. These are the graph, and the sinusoidal graph is found in the fetal anemia and fetal blood sampling. There we have to know the fetal pH. Normal fetal pH is 7.3, and if it is less than 7.2, it is fetal acidemia or hypoxia. Okay, now here about the calorie requirement, it is sometime asked in the NEET PG 22. It is asked. Now this is a topic we have started, antenatal care. Please stay alert. These are small topics. They can cost you one question. Okay, so normal calories required for the sedentary lifestyle. We should know that what is a normal female calorie requirement, and then we will tell that how much we have to increase in the pregnancy. Okay, so for a sedentary lifestyle female who is just sitting and passing the whole day, the calorie requirement is 900 kilocalories. For the moderate lifestyle, it is 2200, and for the heavy work or the labor class, in the moderate comes all the working women, all the teachers, all the doctors, they come in that. And in the heavy work, it is 2900, the labor class people. Okay, for pregnancy, we have to add 300 more calories. Okay, in all the trimesters, especially from the second trimester. Williams say that we have to add 0 for the first, and for second we have to add 340, and third we have to add 450. Now it depends what is your question, accordingly you have to modify your answer. I have given you the whole literature. This was a question asked in NEET PG 2022, that the female visit at 12 weeks. Now as per William, it is 12 weeks, and we should not add a penny calorie. So there was no option like this 0 calories required. So we have to give that calorie. So it will be 300 throughout the pregnancy. No 400, 300 figures were not there in the William. Now let's see. These are the Leopard maneuver. Okay, so Leopard maneuver is assessing PA. We have to do the PA. This first is the second maneuver. Leopard second maneuver. First maneuver is the fundal grip. Okay, we know the fundal height and the part in the fundus. Second is this is the lateral grip. We have to stabilize the fetus with the one hand and then move the other hand. And this is the third grip, and this is also known as pollic grip. This all the three grips we do while our face is in the front of the mother's face. Okay, and the fourth grip, our face is toward the mother feet. We change our direction, and there we insert the hand like this in the pelvis, and we see the engagement. That is the fourth grip. Okay, usually 2 grips are asked, second and third, so that is why I have made the picture like this. Okay, so the Leopard third maneuver is pollic first grip, and Leopard fourth maneuver is the pollic or pelvic second grip. Okay, okay. Now the GPL scoring, some students also have confusion in this. What is gravida? Gravida, if you also have confusion, you just learn it like this. The way I tell every student, gravida means number of times the lady has got pregnant. Sometimes also it's confused also me sometimes. So what I have make is gravida is number of times the UPT is positive. Okay, number of times the UPT is positive. So now you will know that it includes all the abortions. For the twins, only one gravida is counted, because in twins UPT comes positive only one. Okay, so what is para? What is para or what is parity? Parity is, yes, parity is number of times lady has entered delivery room and delivered more than 28 weeks. Okay, number of time the lady has entered the delivery room and has delivered the fetus more than 28 weeks. ठीक है, डिलीवरी रूम में कितनी बार एंट्री हुई है? तो ट्विंस के लिए एंट्री तो एक ही बार होगी ना, ठीक है ना, और 28 वीक्स से अबव होंगे तो उसको हम एक पैरिटी गिनेंगे, और ग्रेविटा इज number of times the UPT is positive, and the third condition is live means number of the live fetus. Now let's see this example. This is her second pregnancy. First pregnancy से उसको 4 साल का बच्चा है, is having 4 years child, and her parity index, first she was having 2 live children and it was a twin delivery. So as it is second time UPT has come positive, so it is G2, and before she has entered the delivery room only once and given the birth to twins, so parity will be 1, so G2 P1. Okay, I hope it's clear to all of you. Second last question of the day is infraumbilical flattening in the case of occipito-posterior. As you all know that occipito-posterior is the most common malposition. Okay, most common malposition. So you can see here that in this slide occiput is at the posterior back of the mother, and here occiput is anterior, right? So when the occiput is posterior, you can see here that the curve is not made, because here comes the face and chin, so there is infraumbilical flattening. Okay, and here when it is anterior, this is most common, and there is the shape of the abdomen is round, and here there is infraumbilical flattening. Okay, you can see here that here the back is here, and here the back is here. So fetal heart rate is seen on the spino-umbilical mid, and here it is seen in the flanks, literally. Okay, so my baby was occipito-posterior. Okay, so there was infraumbilical flattening, and there was my fetal heart rate was also auscultated in flanks. And what are the symptoms of occipito-posterior? There is premature bearing down, urge to pass urine, and early rupture of the membrane. I suffered from all these 3 symptoms. Okay, I started bearing down at 5 centimeter itself. Okay, in spite of knowing the hazards of premature bearing prolapse, that there is vaginal prolapse, in spite of knowing that hazards, I was bearing down because it was not in my hand. I had got occipito-posterior positioning of my baby. Okay, so let's study the last question. The second last question of today is how to calculate the EDD. So 2 things are there. One thing is that whether the LMP is reliable or not. First you have to see if the LMP is reliable, then you have to focus on the LMP, and you have to add 9 months and 7 days. That is a Naegeli's formula. Okay, and then you can know that, then you can calculate the EDD. Okay, whatever is the LMP, you have to add 9 months 7 days, right? And you will know the EDD, but only the thing you have to keep in mind that LMP is regular or not, right? Periods, they are now in this question the female was taking OCPs from 5 months, and there was a OCP failure case. So as you all know that in OCP there is no natural menses, there are artificial menses, OCP induced menses. So we are not going to rely on his LMP now, and here we have to go with the CRL. So if the patient is coming to us in the first trimester, we have to rely on the CRL. If the patient is coming to the second trimester, the most promising diameter is biparietal diameter. In the third trimester, the most promising diameter is the femur length. So we have to only and only rely on the LMP if it is regular and it is natural. Okay. Now the last question, last slide is how much minimum number of antenatal visits the lady has to give while during the pregnancy. First, WHO used to say that the minimum number of visits are 3, But in 2018, in 2016, first the WHO changed it to 4, but in 2018 WHO has made it 8. Okay, WHO has made it 8. So you are going to read carefully whether it is asked, whether they have asked minimum number of antenatal visits as per WHO, as per Government of India, or ideally as per WHO it is 8, as per Government of India it is 4, and ideally it should be 12 to 15. So how ideal antenatal checkup goes is, see, it is every month up till 28 weeks, then every 15 days, 28 weeks to 36 weeks, then every week after 36 weeks. So that was all the important discussion about the fetal surveillance and antenatal care. No need to say you again that fetal surveillance has gained importance these days. Please don't read this topic superficially, go through deeply. Do subscribe my YouTube channel, and if you want any more videos, do write in the comment section. I will make for you. Thank you.